the February 11th, 2021 COVID-19 clinical rounds. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration, and thank you to the multiple professional organizations who have collaborated on these rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience rather than recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Struminger and his stellar team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Mondays are EMS. This coming Monday, which would usually be EMS rounds, is President's Day. In support of the holiday, our clinicians' mental health and fighting fatigue, we're canceling next Monday's EMS rounds and we'll restart EMS rounds the Monday after next. Tuesday will be critical care rounds. That will be focused on the challenges of not critical care, but after discharge from critical care with work on trying to sort through COVID clinics for the long haul patients. And then on Wednesday, we have an HHS Emerging Outpatient Therapeutics session that will be again next Wednesday, and then Thursdays will be emergency department rounds. We also realize that based on the chat that we've had recently in rounds, some new clinical patterns are emerging with COVID patients, and we're going to start to try to tackle some of those. I'm going to now turn this over to Dr. Struminger for some logistics. Thanks.
Thanks, Rick, and welcome everyone. Thanks for taking time out to join us today. And in particular, thanks to Angela and Jack for being willing to share their experience on this super important topic of mental wellness for providers. I'm just going to go over the usual logistics and housekeeping. We really want your questions and comments, so please put those in the Q&A function. We'll be monitoring that and try to get to as many questions as we can. If you have any technical or logistic issues, mention that in the chat, and we'll do our best to help you out. We are recording today's session, as we always do, and your attendance is consent to be recorded. Thank you. Today's presentations are either linked in the email that went out this morning, but if they're not, we will be sharing them on the Clinical Rounds website, which we'll share in the chat. And the recording will also be available on our Clinical Rounds website within a day or two. We are offering CME and continuing education credits through the University of New Mexico, where Project ECHO is based. There should be a link in today's email announcement for that, and we will share it in the chat 15 minutes before the end of today's session. You'll have 48 hours to complete a brief 2 to 3 minute feedback survey. It's how we improve these clinical rounds and take your input into account in planning for future sessions. So please share your feedback with us. Just as a reminder, these learning sessions are focused on improving patient care and health systems and supporting clinicians. Let's keep them apolitical and non-commercial. Thanks for that. And just a word about data use. The data you share with us when you register, when you answer the polls, Most of it's de-identified. We keep all of it confidential and steward it carefully. And what we share with Rick and Asper is all de-identified. Rick mentioned that NETEC, the National Emerging Special Pathogen Training and Education Center, is a partner in this clinical rounds initiative. They have their own terrific webinar series, and they have a webinar coming up tomorrow on mutations and variants of SARS-CoV-2. Very timely topic, and we recommend, if you can, that you join that. They record all their webinars and archive them, so you can also go to them later if you aren't able to go and attend live. And we'll share a link to that in the chat. Rick mentioned there's an outpatient therapeutic series, mini-series that we've been doing on Wednesdays. The interest in monoclonal antibody delivery has been increasing over the last month, and the experience with implementing that therapy has grown a lot. So we encourage you to join us. This was from yesterday's session. So there'll be another session next Wednesday with several cases of local implementation and a panel of national experts. Also, the AAMC is a partner in these rounds. They have a great clinical guidance repository. They've been building it since the beginning of the pandemic, and they keep it updated, and it's a great source of up-to-date guidance. So we'll share a link to that in the chat as well. With that, Rick, back to you for today's crowdsourcing question.
Thanks, Bruce. Well, with today's focused on mental wellness, mental health, it seemed extraordinarily appropriate to ask this question. How are the mental health, mental wellness challenges for clinicians different now compared to July 2020? Seems, actually, when I say July 2020, that seems like about 20 years ago right now. Yeah, but how are they different now compared to then? People aren't shy in the chat, so please jump on that, and much appreciated. If each of our panelists could please take themselves off mute briefly, introduce yourselves, and I'll start with Dr. Seibold. Harry.
Hi, my name is Harry Seibold. I'm an EM and EMS physician from Helena, Montana, past state EMS medical director for Montana, currently on a long-term COVID assignment in Odessa, Texas, in the ICU here.
Thanks, Harry. Sandy, always great to have ACEP represented by you here.
Thank you so much, Rick. Sandy Schneider, Associate Executive Director for Clinical Affairs for ACEP, also a practicing emergency doc in Fort Worth, where I understand there is a pileup of 100 cars right now, and trucks. If you haven't seen the pictures, they're impressive.
No words. Oh my gosh. Okay. Yeah. Dan Gerard.
I can't top that. My name is Dan Gerard. I'm a paramedic and a registered nurse. I'm the president-elect of the International Association of EMS Chiefs.
Great, as always, to have the EMS chiefs represented. Carol.
Good morning. I'm Carol Cunningham. I'm a practicing emergency physician. I'm also the state medical director for the Ohio Department of Public Safety Division EMS.
Thanks, Carol, for being able to join. Dave.
Hi, I'm Dave Thompson. I'm one of the emergency medicine faculty at East Carolina University and the medical director for Vidant East Care, the critical care transport service here.
Thanks, Dave. Thanks to all our panelists for joining us. It makes for a good dialogue, good discussion, and we learn together better for you being on. With that, I'd like to introduce our first speaker today and really welcome Dr. Angela Chen, Assistant Program Director in the Department of Emergency Medicine at Icahn School of Medicine at Mount Sinai in New York City. Angela, welcome, and look forward to hearing from you.
Great, thank you so much for having me. So I'm just going to go ahead and share some slides that I have. And just to give you a little bit of background in terms of kind of what we've been dealing with. So I am an emergency medicine doctor at Mount Sinai. It's on the Upper East Side, East Harlem, right on the border. And we actually had the first case of COVID in New York State on February 29th. And from there, it really was an incredibly quick upshoot where we were quickly seeing, 10, 20 COVID patients coming in a day, all needing to be intubated, all severely ill. We have our residents who also rotate at Elmhurst Hospital, which I think gained a little bit of a national reputation as the epicenter of the epicenter. It was a community that was hit particularly hard with COVID. It is a city hospital. And at that point, everyone in our emergency department, from physicians to nurses to even EVS, were overwhelmed and truly, really unsure of what to do with this sudden spike in our numbers.
Hey, Angela, real quick, can you do the presentation mode?
Oh, yes, I'm so sorry.
No, it's okay. No big deal. It's no big deal.
Sorry, I'm not sure what you
Yeah,
guys.
if that's the worst that happens like in a century,
Yeah. Let me see how I can do this. Let me try to share again.
That's okay. Yeah.
Yeah, Angela, when you put it up, just,
Is that, you guys are still not seeing presentation mode, are you?
not quite.
Okay, let's see.
You may need to adjust your display settings.
Yeah, Angela, while you're working on that, there's a comment in the chat about Sinai represented again, and do want to shout out and to your institution for sharing you and your colleagues' expertise and experience.
Absolutely.
That works. You got it.
Okay, wonderful. And at this time, I think the mental health resources, as we'll go through, really focused on how to handle this new disease, how to handle the surge of patients that we were seeing. We actually built ancillary hospital rooms, if you can see in this bottom screen right here, in the atrium of our hospital. We also had a field hospital go up in New York City. We were featured in the news, just really bringing attention to this surge and how we would deal with not having the resources to handle the numbers that we were seeing. At this time, we implemented a needs assessment to really get at what stressors were causing our employees the most mental distress. And really what we found was most of the concerns had to do with their personal safety, as well as the safety of their families and loved ones, how they would be able to prevent bringing the virus home from work, how they would manage to keep themselves safe with PPE, how they would get themselves to and from work. And I think very interestingly to note, Mount Sinai as an institution was very quick to recognize the emotional toil that this could have on providers, and quickly implemented a mental health hotline staffed by Sinai psychiatrists that our clinicians could use. Interestingly enough, one person cited mental health from this needs assessment that was done in May as one of the sources of stress from dealing with the COVID-19 response. The top interventions that our clinicians found to be really helpful were really, once again, dealing kind of with the more concrete difficulties of working on shift, getting to shift, and how to handle exposures both to themselves as well as their families. And in this way, we found that the way that our hospital administration could be the most helpful was really to have clear-cut contingency plans for potential exposures, to to provide clear lines of communication regarding food, transportation, places to quarantine if a provider was exposed, and also very transparent information about our PPE supplies. At this point in the pandemic, especially with the surge, everyone was really responding to the immediate threat in front of them. And I think at this time really did not have the mental space to reflect on the emotional toll of what they were seeing on a day-to-day basis. And we found that some of the interventions that we introduced, such as locating housing for people who needed to quarantine away from their families, getting our physicians and nursing and techs scrub access so that they could easily change in and out of clothing at the hospital rather than bring anything home, were two huge interventions that our staff really felt made a huge difference back at the peak of the pandemic in really March, April, and even towards the beginning of May. Since then, things have obviously changed quite a bit in New York City. Our numbers have thankfully gone down quite some, and they're nothing close to what we saw in March and April at the height of our surge. But also, I think that change in volume and that time and that space from that initial surge has really given our providers and our staff some time to reflect on their experiences. And I think this in some ways has been really, really challenging, because I think that the mental health toll that the surge really took on everyone who worked in the emergency departments and the ICU is really starting to show. One of the really most unfortunate things that I keep hearing from this is, I don't know if I want to be in medicine anymore. And I don't know if I can do another surge anymore. It's at this point where I think a lot of people have been talking about the sense of fatigue that has set in amongst our caregivers. And I think this is really, really the point to hit home here, that emotionally and from a mental health perspective, the frontline providers that everyone was celebrating at the peak of the surge, we're not really doing okay. We're surviving from day to day because it's what we've been taught to do. But everyone is truly emotionally exhausted. We unfortunately don't have the results from our needs assessment that we just sent out back yet. But we do have some preliminary data in terms of referrals to the psychiatric department, as well as the other mental health partners that we have relationships with. And referrals from the hospital, from the department, have really quadrupled since the peak, really even since July. And I think a lot of that comes from the fatigue that we've talked about, that in 2 weeks, Mount Sinai will have had a year of COVID, and it has truly, truly eroded, I think, at the heart of who we are and who we are as physicians and who we are as human beings. And so going forward, it has never been more clear to us as a department and as an institution that we need to heavily, heavily invest in mental health resources for our staff. It needs to go beyond kind of on-shift well-being. It needs to be so much more than providing a phone number to call in times of distress. And I think really what we're realizing is that we need to figure out a way to streamline the mental health process for our providers. How do we make it easy? How do we destigmatize it so that after facing this truly traumatic event, that we make it okay and not challenging to get mental health to get mental health care easily? How do we start thinking about the mental health model for physicians as a preventative health method model rather than something that you seek out only in times of distress? So moving forward, those are the things that we're really looking into. Luckily, in New York City, there have been so many organizations that have already recognized this incredible need. These are just a couple of our partners. So as I mentioned, our own psychiatric department has kind of created a peer support network for people to call in. There was a physician support line for the COVID-19 pandemic, as well as a couple of nonprofit startups that have reached out to provide subsidized mental health care for healthcare staff, because from where we are from the very beginning back in February of 2020 to now, I think we're struggling. I really think that it's been quite a year. And so we really need to take action to protect everyone who's been through this. And that's all I have.
Angela, that's a lot. Yeah, that's a lot. So one observation, and I was really surprised to see the food and drink being like at the top, when you did the early, and as soon as I saw that, I went back, I flashed back to one of the rounds we did probably in the early spring last year, maybe April, May, where one hospital, small hospital, like 125 bed hospital, had overhead announcements every hour for the drink water and clean your space break, every hour, an overhead page. And then I see your food and drink, and I also flash back to my own department administration decided they were going to take the coffee out of the break room, and what that did to the department. Oh my gosh. It reinforced something that you take for granted. But what was the thing about the food and drink that they were concerned about? Going to places because more exposure to get, go to the cafeteria, or what was it? They were too busy. What was that?
So you have to remember that at the height of the pandemic, New York went into lockdown in March. So people didn't have access to grocery stores.
Okay, all right. It's the access piece. Yeah, okay.
It's access. We were also kind of working longer hours. And so people were just kind of really unable to be able to feed themselves. It's as crazy as that. It feels.
Yeah, I mean, it just that one just really popped. I got a lot of other questions, but I'm going to turn over to the panelists for maybe just one question before I then turn it over to our next speaker. Question or comment from any of the panelists before I go? All right, they want to hear from Dr. Roselle. So do I. That's great. Our next speaker is Dr. Jack Roselle, Medical Director of the Resolve Crisis Services of the University of Pittsburgh Medical Center at the Western Psychiatric Hospital there. He's the Associate Professor of Psychiatry and an Adjunct Professor of Law at the University of Pittsburgh, and past President of the American Association for Emergency Psychiatry. And as you got your slides up, Jack, I just want to let the our participants or acknowledge that this is a new reach for rounds, in that we've had psychiatry on the rounds for the first time, and it was it's time. It's just time. So Jack, really appreciate your willingness to share your observations with us. And thanks to Sandy Schneider, who connected me to you. Thank you. Over to you.
Thank you so much for having me. I'm thrilled to be here, and hopefully I'm going to be able to give you some useful ideas, concepts, tools to bring back to your teams and your programs. As a quick preface, I have no formal disclosures. 20% of my time actually is paid for through FEMA, but it has absolutely nothing to do with this kind of stuff. It's actually counterterrorism stuff, of all things. I've been working in emergency psychiatry for 30 years, most of my life at this point. And I've been doing disaster psychiatry now for more than half of that. And I approach this, both as the operator and also as the medical director, where I gotta think about doing this stuff, and I also got to think about leading and coaching the team. And a lot of the skills that work for disaster response are completely unlike what I got in my psychiatry residency. It's how to make good decisions with limited resources and imperfect data, stress and adversity, the stuff that is often sort of the day-to-day work experience of all of us on the emergency side. And it's about understanding what those conditions do to our performance today and what it does to our minds and our brains in the days still to come. It's embracing the idea that the right skills and knowledge that work for that 50-minute hour of psychiatry really aren't going to help you when you're mucking about in the mud outside of a mine collapse, talking to the families and the workers there, in the middle of a debris field, or outside of a crime scene after a shooting. And it's understanding also that we're under some very real constraints, and we got to figure out, how do we succeed in our clinical mission, even when there's so much in the environment that's pushing against us, both at a systems level and also against our individuals. It's interesting. If you'd asked me, a year and a half ago, what the landscape was as far as morale and burnout and mental health and healthcare, I'd say it looked pretty grim. And over the past year, we've added a lot to our plates. And we've added a lot of resources too, but I think we've probably added more on the burden side than on the relief side. Okay. Well, how do we think about what we do, right? It's strategy and tactics. And, Dr. Chen mentioned just, the basics of food and hydration and caffeine, right? That Maslow's hierarchy of needs, we got to start at the basics. If we aren't addressing our basic physiologic needs, our safety needs of PPE, and am I safe? Am I not bringing home some scary bug that might hurt my family at the end of the day, right? If we're not addressing those things, we're not going to get to all that higher functioning fulfillment stuff, which is where all that cognitive work is that we do in emergency care, right? And it's tricky, right? There's a timing to it, right? There's a reason that y'all are like managing the airway and administering the Narcan before you're calling me and my team to say, hey, come talk to this person about rehab, right? They're both really important parts of healing and recovery. But, we got to do some of this in sequence. And there's sort of like a time and a place for everything. And yet, here's the paradox, right? Even though this is a really weird time to be talking about resilience and wellness, a lot more of it's about coping. We still got to find a place to fit that in. We've got our slow skills for resilience and wellness. We've got the quick coping stuff. And we've got to find a way to balance it. It occurred to me last night, I was driving home, that these slides actually begin, some of them begin in a slide deck about sort of crisis brain and coping skills in a disaster. And then a few years later, they morphed into talks about, resiliency and wellness for physicians. And now it's endurance. It's how do we stay on mission for for those who depend on us for their clinical care, and at the same time not burn out our resources, right? And again, a lot of it comes down to beginning with those basic needs. And yeah, caffeine's one of those. Ask me about the tabletop exercise where I said we ran out of coffee. I got burned for that one, right? Well, I think a lot of you probably see this next slide, the Zunin and Myers model of a disaster. You probably see it in your dreams now. And this was sort of our classic paradigm for what disaster response looks like from a sort of a community response psychosocial perspective. And it's really well designed for a punctuated event, a structural collapse, a mass shooting, a plane crash, something like that. Bad, horrible thing happens. There's that immediate field response extrication. The paramedics are doing their magic. We get folks to the hospital, and then it eases off a little bit. And you can see the time scale. There's like, hey, look, here we are, 1 year anniversary. But that's not what COVID has looked like. It has been ongoing and varying intensity. And it's this sort of multi-disaster. It's the illness, it's the psychosocial stuff, it's the economic stuff. It's, how do I back up my wife as she's taking care of the kid at home when I'm coming home exhausted myself? All these really complex different layers, right? And we have our baseline skills. I saw this recently and it really resonated with me. And I think it might resonate with a lot of this idea that as health professionals, we put our stuff in a box. By the time I get home, my work stuff, it's in a box. And I try to keep my work box of stress at work and my home stress in a different box, right? But sooner or later, we just can't do it anymore. The fatigue is real, right? Exhaustion and endurance are the themes we're dealing with today and we'll be dealing with for the future. Right? Okay. And I saw this, last summer, and again, it really sort of resonated. Like, I don't want yoga. I want the ability to order the test. I want the right PPE. Wellness and resilient stuff is great and it's essential. In some ways, it's what can really keep us going, but it doesn't necessarily make us safe from the day-to-day work environment. And as leaders, we've got to make sure that we're attending to that safety. Meditation and yoga can be incredibly helpful. But if you're stressed out about what about my PPE, I haven't had a day off in 2 weeks, it's maybe not the right time to start those skills. And at the same time, we've got to be doing our clinical work, even when we're exhausted and fatigued and burning out. One of the recent surveys that came out from Medscape about burnouts, so the biggest factor that's contributing to it, it's the bureaucratic stuff. It's the hours worked, it's the fatigue, it's the lack of respect from leadership and administration. It's worrying about the PPE, it's death by 1,000 clicks with our EMRs. And so we've got to sort of rethink what we're doing, right? Disasters amplify the problems that are already there, and this one is no exception, and it's prolonged and it's extended. And our models don't really fit. It's psychologically and morally traumatic. And a lot of our coping strategies and supports, our CISM programs right now, I'm wearing a lanyard that says CISM ASAP staff support because I'm part of our system-wide CISM team. It's extended and exhausting. Like how do we preserve staff and make sure that we've got enough bare minimum staff to manage our ERs and intensive care units, not just for the next 8 hours, but for the next 8 weeks, 8 months, knowing that we're not entirely sure what's coming next with, all the new variants and everything else. What it looks like today in Pittsburgh is not what it looks like in Peoria or New York or Arizona or rural North Dakota, right? It's a prolonged disaster. It's an intermittent disaster. We have to find the opportunities to get in some of those wellness interventions. We've got to find an opportunity to provide a lot of those crisis supports as well. And oh yeah, it's politicized, right? We have national leaders saying, doctors, you were lying about the diagnoses that you're seeing. How utterly demoralizing for what we do. By the way, back to that Medscape survey, 80% of the respondents said their burnout began long before COVID. Okay. And even the best specialties like plastics and derms, still a third of them were feeling burnt out. And psychiatry and emergency medicine were in the mid-40s on that, right? And in fact, when people were asked, what have you done to reduce the burnout? The modal answer was nothing. And by the way, when asked, would you participate in a work-sponsored burnout prevention measure, 40% of them said very unlikely to participate, right? If you've got a diverse team, if you've got 20 docs or 20 paramedics on your team or 20 nurses on your team, you probably need to offer them at least a handful, maybe 20 different ways to provide the resources and supports, because especially the docs were a little fickle, we're a little picky, right? So we got to have a lot of different ways to reach our audience. A lot of different tools, whether it's the buddy program, whether it's CISM supports, whether it's, opt-in or opt-out therapy supports, whether it's something else. Repetition is helpful, right? We all got crisis brain right now. We're fatigued, we're fogged, we're not remembering, we're not thinking clearly, but we got to find the balance where we're nudging people towards healthy resources, but not nagging them, because that's just going to piss us off, right? You can't fake credibility. You got to earn the trust, not assume the trust. And we don't want to do well washing, right? If the leadership team is only talking about wellness issues in the middle of a crisis like that, it reeks of a credibility failure, right? And by the way, as the crisis ebbs, I'm still, as a behavioral health professional, I'm still really worried about the sequelae, both the PTSD layer of it, but also the suicide risk, right? If you've got someone on pressor support for a while and then you just pull it away, what do? They crash on you, right? When we've been running on adrenaline and I know some of y'all in emergency medicine are a bit of adrenaline junkies, right? When you're running on adrenaline and it drops away, people kind of collapse physically and emotionally. One of the times when I worry about suicide in cops, it's not just during their duty years, it's shortly into retirement when there's, you know, no more adrenaline and a lot less structure time. Relationships matter, that personal connection, that feeling of trust and safety with someone that you work with, someone on your team, that buddy model. And again, appreciating that even at the best of times, our work is wonderful, but our work has always had that personal cost. And it's certainly amplified now. And we've got to find ways to be thoughtful and respectful about that and recognize that, yeah, suicide is a risk. By the way, in that Medscape survey, about 1 in 6 docs talked about suicidal thoughts. There's nothing about being a healthcare professional that protects us from those risks. And it is just as you wouldn't leave me on the ground if I had a stroke or a diabetic emergency. I'd hope you wouldn't leave me on the ground if I was talking about being depressed, hopeless, or suicidal. It's what we'd ask from any of our colleagues. This is how to reach me. I'll leave that up there for a second, by email, by phone, by Twitter, and in the slide deck, which I think they posted, there's a bunch of references as well. And I'm always happy to share resources with anyone who might need them. So thank you. I hope this was helpful.
Jack, you reinforced for me, it was the right time to bring you in.
Good.
One question, then I'm going to turn it over to Alice for a couple of minutes before we do polls. We talked about this in the quote unquote green room before we started, but then also you alluded to it, this is so different. And, in previous part of my career, a clinician would come to me and say, I'm in some real trouble, mental health trouble. That was code for mental health trouble, and need some help. Do you think that today clinicians, and maybe you don't know, it's fine too, your thoughts on, do you think, given how things have changed so dramatically, that clinicians in general are able to identify and have enough self-awareness about, okay, I'm in trouble and I need some professional help? Or has it gotten so murky with the combined complacency, fatigue, and all the stuff and the long drawn out that maybe we've got blind spots that we didn't even know we had? I'm perplexed by that, really am.
Yeah, like I said, when you're exhausted, when you're stressed, our brains, our frontal lobes are not working as well as they normally do. And it's been a long, long year. And we get tunnel vision. And so people may not be thinking, I'm in crisis. I need a crisis counselor. I'm having mental health issues. I need a therapist or a psychiatrist or, an EAP program. They're thinking, I can't go home and have a conversation that starts with, how was your day at work again? Because I don't have the words myself. I wish I could go home at the end of the day and have a conversation with, how was your day at work? Because I'm so isolated, because I have work, and in the year of COVID, I'm isolated because I don't have that immediate family right there like some people do. People don't necessarily say, I have a crisis. They say, I'm having a housing issue, a money issue. Maybe I'm drinking too much. We need to make resources available from as many different angles as possible, including as many different sort of tags and flags as possible, where people might say, hey, I need help with housing. I need help with my sleep. I need help with my stress level. I need help because I'm feeling angry and irritable. And I just noticed that I snap at coworkers that I'd never want to snap at, because they're awesome and wonderful. And maybe they did screw up that one time, but boy, that was even more asshole-ish than usual for me. And that was sort of my warning sign, right? We need to find those different ways for people to recognize they need help. And we need to find the different ways to offer the services, Like I said, I wear this lanyard for our ASAP team. That means anyone in our medical system can come say, hey, Jack, I need to chat. And it's privileged, it's confidential, it's I can provide that support. And you know what? Some people are very comfortable coming to me, and I bet there's a lot of folks who are never going to be comfortable coming to me because I'm the doc, I'm the shrink, I'm the boss, whatever. So what? We got a lot of folks on this team, and someone that maybe looks like you, maybe is in your role, or maybe you've never seen before, and that's exactly why you want to talk to them, right?
Yeah, thanks, Jack. Appreciate that. I'll turn it over to our panelists for any questions or comments they might want to make. The raise the hand thing. Okay, Dave oh gosh, all right. Each of you, and so let me do three of you, and then I'm going to do the polling, and we'll get back to the rest of you. Okay. So Dave Thompson.
Yeah, those were wonderful presentations. A question though, you both talked about using the mental health resources, and maybe Jack can address this. Who's taking care of the mental health providers?
Yeah, our therapists, some of them are getting pretty burned out too. Unfortunately, I needed a really good trauma counselor about 10 years ago. But boy, I am so grateful to have her in my life now. We have sort of layers and networks of support. We do a lot of cross monitoring with ourselves, but yeah, for a lot of the crisis and a lot of the therapists I know, they're feeling it too. And like I said, this is a more widespread, deeper, more complex disaster than we've had in a while. It's one thing to fight a fire. It's one thing to fight the fire when the building it's burning down. So.
Thanks, Carol.
Thank you. Great presentation. One of the things that I mentioned with Rick, I was a presenter on physician suicide a few months ago. And, the one thing we need to have is data. And I just wonder, is there any way that we can convince CMS to add a billing code for COVID related, we have COVID related disease if somebody, throws a PE and they've got COVID, but we don't have anything for depression, suicide, et cetera, where that's linked. So I think we're missing a lot of cases. And then one of the things I mentioned during my discussion, I realize the buddy phone call, the buddy system works for some people. It doesn't work for a lot of people because I tell you, to me, it would be worthless. I'm not, yes, especially because everybody I know is burned out. Am I going to call somebody who's burned out to help me? No. I think it goes back to the fact that we need to make a cultural change within our own profession. That, and the analogy I used is that, in emergency medicine and EMS, we're always the heroes. And, we have to realize that Superman doesn't live his whole life in a cape. He spends most of his time as Clark Kent. So I think we need to start very early, even in medical school, to make sure people stay, I just want to be Carol at the end of the day. I don't want to be Dr. Cunningham. And my friends know that, I haven't given up a lot of my high school stuff. I just, and right now that saves me. So I just think we need to make a cultural change and realize that this is unprecedented, but prevention is the key. Someone, if the phone buddy system works if you're just slightly depressed, but the people I know that are truly depressed are too depressed to pick up a phone.
Yeah.
They'll pick up a gun or a noose or a bottle of pills before they'll pick up a phone because of that hero attitude.
Hey, Carol, specific to the CMS piece, believe me, I don't know the bank that well, but shoot me an email on the coding thing, okay? Yeah, and I can at least forward it,
But Dr. Does it exist?
The special code, I don't know. Now, we could come back and have a whole separate discussion about what the impact of the extended pandemic and related disasters have been on mental health presentations. Interestingly enough, as best as we can tell, there's been no broad impact on suicide rates, but I will bet good money that there are some subsegments that are being incredibly impacted. and other segments that aren't being impacted at all. And that's why it's sort of, we're not seeing a change because we're not looking at the diversity of the populations it's impacting. But you certainly know in your position that from the time of death to the time that we actually have a piece of data that says this is how or why someone died, makes it generally too long to really be able to do some good problem solving. But suicide rates have gone up for the last 20 years nationally. I'm not optimistic that 2020 will be the year that we turned it around.
Well, I wouldn't even limit it to suicide. I mean, think about PTSD. When 9/11 happened, was there a billing code to link it to that event?
It's a great question. I don't know. That's an excellent question.
But that's what I think needs to be developed, because before you become suicidal, you've got depression, anxiety, PTSD that can be linked to this COVID pandemic potentially.
And what we have seen is we've seen a surge in, our primary care clinics. Doc, I can't sleep. Doc, I've got a stomach ache. Doc, it's heartburn. It's anxiety. It's stress, right?
Yeah.
So.
Thank you.
Yeah, thanks. Dan, Sandy, and Harry, if you can hang on, I'm going to go ahead and do the polls, see where we all are. Echo, if you can put up the polls. And thanks for everybody responding in the chat to the crowdsourced question. A lot of insights there. Today, which of the following is the biggest challenge for your organization? All right, let's stop there. 52% of you voted. That's a lot. These results that you're seeing track, I think, pretty closely with what we did a couple months ago with this very same question. I don't have the exact date, but they track really pretty closely, with fatigue being the most frequent response. Interesting, 0 said none of the above are challenges for our organization. Yeah. Angela, you're smiling. You're not surprised either, are you? All right, next. So this one, this is a grand experiment in our spirit of peer-to-peer learning. Since the pandemic, which is the most frequent change you've seen in clinicians just prior to their requiring professional mental health support? Lots of options. Actually, Amy and Amanda with Echo, I had to count to make sure I didn't go over my 10 limit. I had more, but.
If I can, I want to make a quick comment about that complacency answer on the prior one.
Yeah, go, please. While people are, absolutely.
When we think about the trauma response, right, we all remember, back in med school, fight, flight, or freeze, right? Well, freeze, that dissociative trauma response, the deer in the headlights of either I'm so overwhelmed by the situation that I can't move, or there's some part of my brain that knows if I move, the lion is going to bite me, or if I move, the abuser is going to hit me again. That's part of the complacency, is that people just get frozen in place. And, as bystanders, as colleagues, as coworkers, we can do some gentle exploration of, boy, you seem to have a hard time motivating. How much of this is just the exhaustion factor versus an actual fear of I don't know where to go next, or I don't know what to do next.
But Jack, that we were briefly talking about it before, but that line of fatigue and when you're in you really are having some mental health challenges that exceed, I'm tired because I had a long day at work. And that, to me, is a really tricky place we're in right now. Very tricky.
Yeah.
And this conversation reminds me, this is a little bit of a non sequitur while people are trying to figure out what my options were with the questions. But there was a great tweet I saw about a mom who was talking about how their teacher was such a hero, and they showed the video of it. It's the kid was saying it was just so tired of doing the Zoom schooling and his brain couldn't do math anymore. And the teacher said, well, if your brain's too tired to do math today, I think you should probably go out and play. And I was like, yes, yes.
The child psychiatrist and the dad approve of that one. So.
Yes.
But yeah, you know,
Yeah, go
fatigue
ahead.
it's insidious, right? We can be really fatigued, just a little bit less sleep every night, and no one's been sleeping well recently.
Yeah.
And it adds up. And again, it hits our executive functioning. And unlike coming into work with a migraine, or remember when we used to come in with like just that slight fever, not think twice about it, way back when, you know, we know what we're coming into work with. If we're a little bit fatigued, we're blind to a lot of those impairments, which is why, you know, how many of us have had that post-call MVA that maybe was or wasn't our fault, but we probably could have avoided it if we were better rested, right? I've been there. I bet a lot of the folks on the phone have as well.
Yep, thanks. Let's see the results for this. 57% of you voted. I really appreciate people voting. And let people see the results. 27% was the highest percentage response, and that was decreased interaction with colleagues. I personally expected the missed work one to be a much higher response. All right, next. Today, clinicians are generally self-aware of when they need professional mental health support. And I put that to there. I should have put it in bold or whatever, like italics, because I'm talking about today in the pandemic. I'm not talking about like in general over the past 20 years. I'm talking about like now. All right, thanks for jumping on. 53% have voted. Let's see the results. I personally had no preconceived notions about how this was going to play at all. Angela, for leaders in medicine, those results are pretty, actually, I think really important. Yeah. All right, thanks. Next. Today, I feel confident I'm able to identify clinician colleagues who need professional mental health support. And, when I was putting these together, I was struggling a little bit because this is not just like people going to psychiatry. It wasn't about that concept, Jack. I wasn't like, or Angela, I wasn't just like talking about, but I was trying to get to like, when has it tipped to where somebody needs help? That's what I was trying to get to. And I used the professional mental health as like the surrogate best I could.
Angela, I don't know if you want to take first pass at that or.
Yeah. Angela? No, go ahead, Jack.
Yeah. At a very basic level, if someone says, I need help, we want to give them help. If they have an impairment in functioning, and this would be, how are things going at home and sort of your personal life? Are you having more arguments? Are you using more substances? How is it going in your professional life? Do you feel like you're making more mistakes than usual? Are you snapping at coworkers? Are you just not able to get through the shift? Is that usual like 5-minute coffee break, is that dragging on and on because you're just dreading getting back to work? Those might be good warning signs. And certainly, hopelessness, talks about suicide, you know, even jokes about suicide. You know, again, I'm the emergency psychiatrist. I get jokes and I get, you know, dark humor, but I'm still going to explore that. As a very, very basic metaphor, you know, if I was on a gurney in front of you with a broken leg or a hypertensive emergency, and I made some passing comment that made you think, oh, do I need to get psychiatry to consult on this person? That may be sort of the same thing you notice in a colleague or a peer, especially when it's a change from their baseline. Say, I got to figure out how to help my friend.
Yeah. Yeah. Let's see these results. It's pretty fascinating to me. There's an equal, I mean, 24% agree, 23% disagree.
But, you know, only a third feel comfortable that they'd be able to recognize it.
Yeah.
And there's recognizing it, and then there's having that conversation, which is not always comfortable.
Yeah. Thanks. Next, I think that maybe one more. Yeah, there's two more. This one, yeah, okay. It's in my colleague's best interest for me to report my concern that he or she needs professional mental health support to a supervisor. When we go, there's one more after this. It's like a really straightforward one, I think. Yeah. After the next poll, I'll go to Harry, Dan, and then Sandy. Okay. And then Jack and Angela, you always get the last word. Speakers always get the last word. All right, 60% of you voted. That's great. Thanks. Let's go ahead and see these. Well, that's some diverse responses. All right. Leave it up there for another few seconds. All right, next and last one. So this pandemic over thing, and I've seen stuff in the chat already, and I totally agree. This is not like we're over line in the sand, but I had to pick a marker for somebody said it was over. And I get it. I get it. So yeah, this is like for a long-term kind of thing. But after, let's say WHO declares the pandemic's over, I feel confident that without external support, our organization is going to be able to support the mental health needs of our clinicians. And no, I have no idea what the external support means, but can your organization do it alone is what I was trying to get to.
And I think whether or not your organization can do it alone or it needs to bring in other teams or agencies for support, I think it's really important to recognize that, you know, that there's always different stages of disasters and recovery. You know, as one of my trauma surgery buddies says, you know, when the bullet goes clink into the metal pan in the OR, that's not the end. It may be the end of the episode on TV, but it's not the end of that person's recovery or what the team needs to do to get them back on their feet. And the same is true for us. When COVID-19 is magically done and we don't have COVID 20 or 21 or God only knows what else, we'll be licking our wounds from these years for quite a time to come, I think.
Yeah, I frequently reflect back to September 11th and the impact that had on our nation. And you take a look at the number of people killed then as opposed to now. And so
Yeah.
Therein lies how self-evident it is. So let me turn this over to Harry. Oh, Harry, can you hang on for 1 second? Angela, when you saw these polling results, were there any like surprises that like really like popped out, or it's like pretty much what I expected? I'm curious because I mean, what you're doing in your department.
Yeah, I think pretty much as expected. And the one that really, really resonated was just the complacency and the fatigue. That's
Yeah.
really the general sense that we're getting is people are just trying to get through the week, get through the day. And I had someone say, you know, like, I'm really just at this point, just doing the bare minimum.
Yeah.
And that one really resonated.
Quite honestly, they're able to like get up the next morning and do the bare minimum. That might be where they need to be right now.
Yeah.
Yeah. And maybe that's just okay. So anyway, Harry.
I want to thank both the presenters for something that's incredibly important and often we overlook. My actual question was addressed by Dr. Rozell and others in a very brisk conversation over in chat. So I'm just going to leave with a comment. During this time where we're all increasingly stressed and working hard, remember to be good to each other and good to yourself. That is often the hardest thing to do, is to be good to yourself and to have forgiveness. And these are times where we need to really practice being good neighbors and good to each other.
So Harry, you saying like lower expectations? I love it. It's like, no, well, I mean, I think it's actually important right now. Anyway, yeah. So Dan.
Dr. Rozell, Dr. Chen, thank you very much. Great presentations. And I just have a comment to kind of touch on what Dr. Rozell said. You know, lessons learned from the World Trade Center. Today, 20 years later, we still have emergency providers, whether they're hospital, EMS, et cetera, that struggle with addiction, depression, and suicide. And I think what we need to do as a profession across disciplines is look at what we do for onboarding, what we need to start in our organizations for preventative care, and what do we do post-incident immediately, in that intermediate time frame and long term for incidents as diverse as a pediatric cardiac arrest, elder abuse, Las Vegas shooting, or another COVID pandemic. And they all have different implications in regards to length of time. And that's the challenge. That's the challenge. Again, thank you very much. What great work you guys are doing. Thank you.
Thanks, Dan. Over to Sandy.
Yeah, well, first, thanks, Angela, and obviously Jack. You know, we've been working together quite a bit, and he's become my new BFF. I was struck as we were talking about all of this, is that this disaster is not probably going to have an end. That we're going to be able to say, okay, you know, like the bombing took place, the buildings are down. Now we're in the search and recovery, or and then we talk about recovery. This is going to be with us, and it's not like, you know, even now we found out that vaccinating isn't, you know, going to change our lives. I've been struck as we've been looking at the people getting vaccinated, that there are a group of elderly people out there, and some people actually that I work with, who have been sheltering in place basically since January, since March rather, that have very few contacts with the outside world, you know, particularly elderly people who can't Zoom. And what this has done to them, I think, has been potentially overlooked. As you saw people, I know some of my friends have been doing the vaccines, and they say they have talked to people who have said that this was the first or second, maybe the third time they have been out of their house and they live alone. And to imagine what that is like is extraordinarily hard. And I think so. We're all going to struggle, and certainly the economy and the effect on children and all of that is bad. But I just wanted to lay out there that I've been struck by watching the elderly people go through the drive-throughs getting their vaccines.
Yeah, Sandy, totally agree. And, the struggle with vaccines, but also this isolation piece, I'm curious in a scared, curious way as to how what the reemergence of our society. How are we going to act with each other? Somebody said that, Harry, I think he said the kindness piece, and yeah, we got a long ways to go. Last word from Jack and then Angela. Jack, any final comments for the good of the group?
You know, one of my favorite quotes from Carl Menninger, one of the greats of American psychiatry, was, when in doubt, be human. We don't have a playbook for a lot of this. We're going to use our best judgment, as much compassion as we can, and we're going to screw up. And it's going to break our heart when it happens. Whatever we can do to practice a little self-compassion and pick up and keep moving for ourselves, for our teams, for those who depend on us, and for those we depend on, that's what we can do. So.
Thanks, Jack. It was a great, great final comment. Angela.
It's hard to follow that, but I think in a very, very similar sentiment, I think we're all struggling, and this is something that we often encourage, even if it's not for yourself, reaching out to your colleagues to check on them, and really, this is the time, I think, to truly take care of each other. Everyone was just impacted so strongly by this pandemic, and it's very clear we don't have the resources necessary in place to really overcome it. And so showing each other and ourselves kindness and grace, I think, is really going to be the way we make any kind of progress on this.
Yeah, Angela and Jack, the comments, but also chat, I mean, the collective sort of like wisdom of the group here. To me, one of my take home lessons is this actually might be one of the most vulnerable times for us as clinicians, but also as a society with the mental health and wellness challenges. And I'm really glad we did this one. And also, I was like stunned that we actually like had long-term care talking to like intensivists, but now after a long time of my personally being like really reluctant to start bridging into psychiatry, not because I'm all for you, Jack, but it's like, I'm not sure they're ready to talk yet, but I think we're ready to talk. And I really appreciate your opening the door, and to Sandy for like connecting this. I really appreciate it. Angela, one of the things that I think about a lot with Mount Sinai, and we've had, Brendan, others talk, and Jolien talk about the sort of like how you've approached for the department, your clinicians, mental health. It's like this huge plea, and I've already told Brendan this, you gotta help those other institutions that don't have your resources to be able to help them figure it out, because there's so many out there that aren't anywhere close to where you come in terms of like your thought process and the resources you put behind it. So Jack, just really deeply grateful. So to our participants, thank you for not just joining, but a great discussion in the chat. And I know, Jack and Angela, you've been talking a lot, but a lot of like really insightful comments there. To our panelists, always, Carol, in particular, your presentation, when we talked about suicide of a colleague, I think about that a lot, as I do about the other mental health presentations. But thanks for being on always. And to Jack and Angela, just extraordinarily grateful. And it seems, Dr. Strominger, we're going to need to continue this conversation. This ain't over by a long shot. So with that, thanks everyone. We'll see you on the next one. Bye.
Thanks. Thanks, everyone.